Now let's talk a little bit about hypoglycemia. So you receive another phone call, Mr. Brimley, not looking as well there. The nurse calls you again from his room and says that his blood sugar is now 45. He's diaphoretic and uncomfortable. What do you want to do now? So fairly straightforward, we probably want to give him some glucose back. If he's able to take in a normal PO diet, what are some easy things that we might be able to give him? So I wrote down things that are readily available, things like orange juice, apple juice, crackers, or slices of bread. We essentially want to find a simple carbohydrate that can be quickly broken down to glucose, and not something more complex that would take longer to metabolize. But what if this is a patient who's having a lot of nausea and vomiting, is uncomfortable, and is really unable to take in normal PO? What would we want to do in that case? In that instance, we might want to give him either an IV drip or a bolus of something like D5 water, D10 water, D50, which is even more concentrated, or even a glucagon shot. And similar to when we thought about hyperglycemia, we definitely want to recheck this person's blood sugar in about 30 minutes to make sure that it's appropriately responding. It's important that we think about how to prevent hypoglycemia in the hospital. We should always think of all hypoglycemia as serious. Many providers will tell you that hypoglycemia kills people, while hyperglycemia is usually just a nuisance, unless of course they have DKA. It's important to prevent hypoglycemia by maintaining consistency in the meals, regular blood glucose monitoring, and insulin adjustment, and then finally remembering that if a patient becomes NPO or starts tube feeding or has a radical change in their diet, we should seriously reconsider changing their insulin.